Hi, hello. Hello, friend. Hello, student, all of you. So, just I am waiting whether, let me know whether I am audible to you or not. Hi, good evening. Good evening to all of you. So, I hope I am audible to you. Audible and visible also. Right? Just give me a thumbs up so that I can understand that whether I am audible and visible to you or not. Because this is a problem, inherent problem to live YouTube session. You have to respond. I cannot understand. Yes? Okay. Okay, Dr. Gayatri. Thank you. Thank you. Right. Very good. So now what we are going to do, we are going to discuss the MCQs which has just been asked in the last PGI entrance examination, right? So PGI 2020 July session, the MCQ of physiology. Okay, now before starting the session, all of you know that physiology per se in PGI Chandigarh they give only questions around 6 to 10 maximum, not more than that. Okay, but the questions they gives are very tricky and you have to go a little depth into the topic to answer those questions. But surprisingly, I should say that this time questions are on a lighter side. From physiology I am talking about. Okay, so questions are on a easier side, but although some of the options in the questions are very tricky, right? So what I will do, I hope all of you who are attending here, either you have attended the PGI Chandigarh session, the MCQ, the exam you have attended, or you are gaining information for incoming GIBMAR. Both of the students will be benefited from the class. Okay, so try to listen, try to answer whenever the MCQ will be projected here. Okay, so first MCQ that was asked here is this, that which of the following is or are isotonic, right? So simple, this is a very simple question. All of the students can answer some of the option, right? So try yourself that what are the isotonic solution from all of them, right? So dextrose saline solution, that is the dextrose saline solution, then only 5% dextrose, then 0.45% normal saline, then plasma lights and renal lactate. So all of the options you look at and try to answer that what will be the correct answer in this question, which of the following are isotonic. Okay, some of you, if you can answer. Yeah, random, no one. Okay, so let's see what is the status. Okay, so you are thinking, that means no problem. So A, B, D and E, right? Okay, anybody? Dr. Sani has given some answer. Satish, Sohini, all of you. Dr. Nidhi, Dr. Sudha, you want to answer something? A, D, E. Okay, so what you are seeing in this A option, that it's a isotonic looking to you. So dextrose 0.5% saline. Why are you saying this is isotonic? Okay, I'll say this is not isotonic because this is not 0.9% saline solution, it is dextrose saline solution. So please remember, the A is not a isotonic solution. When only normal 0.5% NaCl is given, obviously that's a isotonic solution. But apart from that, whenever you add dextrose addition to the saline solution, so already this is isotonic. Along with that, if you add dextrose, most probably the 5% dextrose, so what will happen, this solution become hypertonic. So this is not my answer. 5% dextrose, all of you have given correct answer, that yes, it's my answer. It's a purely isotonic solution. 0.45% normal saline, obviously this is not an isotonic solution, so cross. Plasma light, right? So This is also an isotonic solution. So what is this plasma light? Please remember, the plasma light is the solution which contain composition which is almost similar to plasma, almost similar to your plasma, including the osmolality, including the pH, and obviously the tonicity. So please remember, this plasma light, this is an important one to remember. It's a purely isotonic solution and composition is same to same with that of our normal plasma, including the pH, including the osmolality, right? A is not isotonic. I'll show you. A is not isotonic. If it is only 0.9% saline, then that's isotonic. But whenever dextrose is added with that, then it become hypertonic. Okay, although there are some kind of dextrose saline solution which is isotonic also. I'll give you. Just hold on. But before that, obviously Renal lactate is also a isotonic solution. So in this question, answer is only B, answer is D, answer is E. These three are the isotonic solution. Now what should I remember from this discussion? If the question is coming in future, probably in coming GMR or NEET exam, so what are the information that I have to remember from here? So I always give you this list in my classes whenever I take general physiology MCQ, that you have to remember that what are the isotonic solution. So whatever is written in this slide, please try to remember each and every bit of it. This is not only important for GMR incoming, also it is important for NEET exam, right? So 5% mannitol. So whenever any solution will be given which is 10% or 20% mannitol, that will be hypertonic in comparison to that, right? Then 5% dextrose. 5% dextrose, it's a isotonic. 0.9% NaCl, this is also isotonic. Renal lactate solution or lactate ringer or Hartmann solution, this is also isotonic. What is not clear, Dr. Punita? What is not clear, Dr. Punita? You didn't understand? You didn't understand what is not clear? So isotonic solution. Oh, visual not clear. Okay. Could you please refresh your page? Maybe my internet is problematic or your internet is problematic. I got afraid that what you are saying not clear means whatever I am saying it is not clear to you, or I am talking something wrong. Okay, so please remember, visual, if it is not clear, just refresh the page once more, so it may give you better visual. So now look at here, one important thing, Renal lactate, okay, and the ringer solution, these two things are little different. Okay, so you have to remember, Renal lactate, which is also known as the lactate ringer solution or Hartmann solution, it is similar to plasma, means all of the composition, electrolyte composition is similar to plasma, except that it does not contain magnesium. So it can be a potential MCQ in any of the exams. So please try to remember, Ringer's lactate solution contains no magnesium, otherwise the solution composition is same to same with that of the plasma composition. And what is Ringer's solution? It is not lactate. So what will happen? Obviously lactate will not be present. So it is the same constituent like that of the Renal lactate without the addition of sodium lactate. So that's why here we are not using the word Renal lactate solution, but here we are using the word Renal lactate solution because addition of sodium lactate is present. But in case of simple Ringer solution, lactate is not there, sodium lactate is not there, otherwise their composition is almost same to same with that of the plasma except magnesium. And just I told you that plasma light, and I have written the osmolality because this is the thing which I have to find out also from the internet. Okay, that what is this plasma light? Okay, so plasma light, they are saying that this is composition is almost same to same, or I should use the same to same, exactly same to same with that of the plasma, including the pH, including the osmolality, right? Okay, so plasma light osmolality is 295 milliosmol per liter. Now I hope all of you know that plasma osmolality is, our normal plasma osmolality is 285 to 290 milliosmol per liter. So if you take any of this solution, if you take any of these solutions, suppose 5% mannitol or 5% dextrose. So suppose you have made a 5% dextrose solution. In 100 ml water, you have given 5 gram of dextrose, right? What will happen? You will going to get a solution. That solution osmolality will be similar to the osmolality of our plasma, and that's why they are known as the isotonic. All of you know this thing, but just for your reinforcement, the tonicity of all of this solution is near to plasma tonicity. It may not be exactly within this range of plasma osmolality, although this is our plasma osmolality, but all of this solution has osmolality similar to or close to plasma osmolality. It may be 310 also, but that will be also known as a isotonic kind of solution because it is very close to plasma osmolality, right? Now here I have written only one thing here. Okay, so look at here. 5% dextrose is isotonic in vitro. It is hypotonic within the body. Based on this concept, the question has already been asked in NEET examination. So please try to remember, if I made a dextrose solution, suppose this is a glass, and in this glass I have made a dextrose solution, 5% dextrose solution. Now whenever I will drink this solution, suppose I am drinking this solution. So what will happen? Inside my body, this 5% dextrose solution is entered. That contain isotonicity. Now it contain dextrose plus it contain water. Now whenever it enter inside your body, right, what will happen? This glucose will be taken up by the cells of your body, and only the water component will remain inside your plasma. Getting my point? So whenever you are drinking 5% glucose solution, 5% dextrose solution, this is purely isotonic solution in vitro. Okay, but whenever it is entering in your body, what will happen? This glucose will be taken up by the body cells, and what will remain? Only the free water will remain in your plasma. When free water is remaining in your plasma, that become a hypotonic solution. That's why it is said that 5% dextrose solution, it behave like a hypotonic solution inside our body. But if you look at the tonicity of the solution, the tonicity is almost same to same with that of the plasma tonicity or plasma osmolality. That's why the two things has been written here. Got it, everybody? Everybody got this thing? Now look at here, that dextrose saline solution. I told you that dextrose saline solution, it can be of isotonic, it can be of hypertonic. So please remember this strength, that if you take a solution of 5% dextrose with 0.225% of normal saline, okay, 2 to 5% of saline, then that is isotonic, means tonicity of this solution is near equal to plasma tonicity. But whenever you add 5% dextrose with 0.45% saline or 0.9% saline, these two solution, obviously it will become hypertonic, means tonicity will be more than that of the plasma tonicity. Because look at here, 5% dextrose only, that is isotonic. If you add slightest amount of saline, okay, salt, then the tonicity still remain close to isotonic. But whenever you are adding more amount of saline, what will happen? The tonicity become hypertonic. That's why dextrose saline solution, depending on the strength, it can be of the isotonic also, it can be of hypertonic, like this, right? So this is the discussion of the first MCQ. Now just tell me whether you understood this thing or not. Whether you understood this thing or not. Now I'm going to the next MCQ, but before that just give me a thumbs up, okay, whether you understood this or not. Okay, please try to remember this information. Everybody, all of you there? Actually there is a lag of time between my voice and when it is reaching to you. Got it now? Okay. So now coming to the second question, right? Okay, so that is a very simple form, isotonic solution concept. Please try to remember whatever isotonic solution example I have written. That is important. Now you come to the second MCQ. Try to answer. I will wait for 1 minute. Try to answer this second MCQ. Which of the following is true, right? Which of the following is or are true, right? Right, very good. Excellent. So this is more easier question. Very good, Dr. Kamal, Dr. Sapnil, Dr. Sani, you have answered. So oxantic cell, they are the isotonic cell. Very good. Excellent. So they are the acidophilic cell. Okay, so that's a true statement. So this is true. Goblet cell are most abundant in stomach. Most abundant in stomach. Do you think this is correct? Okay, do you think this is correct? All of you have answered B is also correct. I am asking whether this is correct or not. What do you think? Goblet cell are most abundant in which region? Any answer? Dr. Nitish, you have answered A, E and C. Right, A, E and C. So you have not answered B. So why I am asking why goblet cell? Yes, please remember, goblet cell, they are present in intestine. Okay, they are, please remember this information, they are present in intestine. In stomach they are not present. In stomach, if goblet cell are present, they indicate intestinal metaplasia has been occurred. So please remember, goblet cell is not present in stomach, right? So goblet cell are mostly present in the intestine. Mostly they are present at the level of ileum as well as colon. Please remember, okay, please remember this, ileum and colon, right? Okay, mostly, so they are present throughout the intestine, but they are mainly present in ileum and colon. And obviously all of you know that goblet cell is the mucus secreting cell. Inside the stomach, mucus is secreted by other cell. Mucus secreting cells are there, specialized mucus secreting cells are there. That's why goblet cell, yes, mucus secretion, but goblet cell are not present in stomach. Inside the stomach histology, if you are getting goblet cell, that indicate intestinal metaplasia has been occurred. Okay, it is mainly present in intestine, throughout the intestine, but mainly in terminal ileum and colon region that is present. Then endocrine cells secrete gastrin. Obviously, gastrin is secreted by endocrine cell, which is present at the level of antrum pyloric region, right? Antrum pyloric region. Then oxantic cells secrete vitamin B12. All of you know that no, oxantic cell is basically secrete intrinsic factor. It secrete the intrinsic factor which is responsible for absorption of vitamin B12, but it does not secrete vitamin B12. Yes, gastrin is secreted by the G cell which is present at the level of antrum and pyloric region. Very good. And parietal cells secrete acid. This is also a true statement. So look at what are the information you have to remember from this. So if you look at the secretion of the stomach, there are main three types of gastric glands are there. One is known as the main gastric gland, right, which is mainly present at the level of fundus and body region of the stomach. So this is very simplified scene, but please try to remember, it can be given in future MCQ. Main gastric gland are present at the level of fundus and body region of the stomach, and it contains three main cells. One is the parietal cell, right, which is also known as the oxantic cell, which was in our question, which is responsible for secretion of the HCl and intrinsic factor. Then it is also the chief cell which secretes the pepsinogen. All of you know that thing. And then this is the EC, that is the enterochromaffin cell and enterochromaffin like cell, right? So please remember, enterochromaffin cell, they are responsible for secretion of serotonin, and enterochromaffin like cell, they are responsible for secretion of histamine. So all of this, they are also controlling the acid secretion. So please remember this. Then coming to this cardiac region gland. So in the cardiac region, there are tubular glands and they secrete mainly mucus. So see here, goblet cell is not there, but mucus secreting cells are there, specialized at the region of the cardiac end and also at the level of the pyloric end. So pyloric end contain two main types of cell. One is the mucus secreting cell and one is the G cell. And this G cell, which I have already discussed, this is nothing but for the secretion of gastrin. Remember, so this is the simple thing that you have to remember, that what are the different cell types in the level of stomach, right? Okay, so that's why in the previous question our true option was A and C and E. Okay, goblet cell are not present in stomach, right? Now I'm going to the next question. So now next question in front of you, right? Okay, so You have to answer now correctly. Try to answer it correctly. Renal plasma flow decreased by, right? Afferent arterial constriction, efferent arterial constriction, ureter constriction, increase plasma protein in blood, decrease plasma protein in blood, right? So let's see. Now I think this is the typical question which is purely physiology, okay, and this question has asked repeated times in AIIMS entrance examination and in various entrance examination. So please try to answer correctly. So Dr. Sani has given, Dr. Nitish has given, Dr. Sapnil, okay, all of you, okay, all of you, please try to answer, right? Okay, so anybody want to answer more? AE. So afferent arterial constriction, obviously A will be answered by every student, okay. E, decreased plasma protein, I don't think so, okay, so this is not true, okay. AE, no, AE is not true. Decreased plasma protein will increase the renal plasma flow theoretically, right? So here remember option A. Dr. Nitish, you are making a mistake. Here they have not asked you about the GFR. So please student, don't confuse between this GFR and renal plasma flow. Here the question is about the renal plasma flow. So please remember option A is correct, option B is also correct, option D is also correct. So answer here is A, B and D, right? So please remember both afferent and efferent arterial constriction can leads to decreased renal plasma flow. So I told you this concept in classes where I discuss about the GFR regulation. So please try to remember like this, you will never forget that. Suppose this is my afferent arteriole and this is my efferent arteriole, right? So these two arterioles has their own resistance. So this is the resistance of afferent and this is the resistance of efferent. Both of these resistance, they are connected in a series circuit. So we all know that in series circuit the total resistance is equal to combination of both of the resistance. So what I am saying that whether you increase or constrict here, suppose I am constricting here in the afferent arteriole or I am constricting here in the efferent arteriole. So what I am doing, I am increasing the resistance here or I am increasing the resistance here. In any cases, whether you constrict the afferent or efferent, the total resistance of kidney, that is the thing that I have to remember. Total resistance of the kidney will be increased whether it is constriction of the afferent or whether it is constriction of the efferent. So now you look at this concept that heart is pumping blood from here. So heart is pumping blood from here. Blood is going in different region, like it is going into the kidney, it is going into the liver also. So it is going into the liver also, it is going into the spleen and all other organ like this. So it is diverted in many regions. Now whenever the blood is flowing with the same pressure, okay, and when the blood is going through the kidney, it is seeing that there is huge amount of resistance inside this kidney. There is huge amount of resistance inside this kidney, okay. Heart does not know that why the resistance of the kidney is high, but I know that resistance has been increased because of the constriction of the afferent or due to the constriction of the efferent. But in any cases, the total resistance of the kidney is high. Whenever the total resistance of the kidney is high, what will happen? The blood will less flow through the level of kidney. Rather, most of the blood will be diverted into the other organ like liver, spleen, like this. So that's why please remember that whenever there is increase in resistance of the kidney, okay, increase in resistance of the kidney, the blood flow, the total blood flow to the kidney will be reduced. Okay, don't think that efferent constriction means blood will normally flow through the afferent and it will be stuck here. No, that is not the concept. First of all, your plasma flow will be decreased, your renal blood flow will be decreased because your total resistance of the kidney has been increased, and whenever the resistance is high, the blood will be diverted into the other organ rather than kidney. So I can understand from here that afferent constriction or efferent constriction, in both of the condition the renal plasma flow is going to decrease. But all of you know that if there is afferent arterial constriction, then GFR also reduces. Okay, but in case of efferent arterial constriction, if the constriction is mild enough, then the GFR increases, because in this condition, when the efferent constriction is mild, the blood which is flowing here, the amount of blood is less, but this low amount of blood will not be able to flow through this efferent arteriole easily. That's why the GFR will be increased initially. But if you cause a severe constriction, then the blood flow to the kidney decreases so severely. That it will not be able to maintain the normal GFR pressure also. Because severe constriction means renal blood flow will be severely reduced. That's why in these cases the GFR will also be reduced. That's why there is a typical curve. Okay, I remember this curve always, that suppose this is the efferent arteriole resistance. So what is x-axis? X-axis is efferent arteriole resistance. Getting my point, student? Okay, and what is afferent arteriole? What is y-axis? Y-axis may be a different parameter. So x-axis is the efferent arteriole resistance. Now look at here. Suppose I am constricting the efferent arteriole more and more. That means I can say this is mild constriction, this is moderate, this is severe constriction. So what is happening? Resistance is rising more and more. In these cases, what is the tendency of the GFR? GFR changes like this. So look at, this is the GFR. And how the renal plasma flow or renal blood flow will change? Renal blood flow was maximum here. Now the renal blood flow is dropping like this. What you are finding out? Renal plasma flow decreases more and more whenever the efferent arteriole is constricted more and more, because this is simple, the formula of resistance. More constriction of the efferent arteriole means more resistance means renal plasma flow has to be decreased, right? Okay, and this GFR is initially rising, then the GFR is generally decreasing. So this is the thing that you have to remember here. So this is important. Now ureter constriction, this is not related to your blood flow regulation, but this will causes decrease in GFR. So this causes decrease in GFR, but not the renal plasma flow. Now all of you know that increased plasma protein, what will happen? Increased plasma protein will increases the viscosity, right? Now if you remember the Poiseuille-Hagen formula, then all of you know that resistance R is equal to 8 eta L by pi R to the power 4. You remember this formula? So here this R, this eta is nothing but the viscosity. So that's why if the viscosity is rising, then what will happen? The resistance to blood flow will also rises. And if the resistance to blood flow rises, then what will happen? The renal plasma flow will also decreases. So that's why increase in plasma protein, okay, increases the viscosity, and increase in viscosity decreases the renal plasma flow or renal blood flow. That is the thing you have to remember. So please remember that viscosity depends on two parameters. One is the cellular component, that is the RBC, WBC, whatever the cell which is present there, okay, mainly due to RBC, and second is plasma protein. These two things. So whenever they are increased, like suppose polycythemia, then viscosity will be higher. Suppose there is huge amount of fibrinogen, huge amount of globulin in your plasma, then also your viscosity will be rises. Now I'll ask you one important thing, okay. This is viscosity is the thickness. This is viscosity means it is thickness, how the plasma is thick. Decreased plasma protein causing increased third phase fluid, reduced intravascular volume of blood, so reduced renal plasma flow. Theoretically that is possible, but for that the decreased plasma protein should be very, very severe, okay. And after decrease of that plasma protein, what will happen? There should be severe edema, and then also it's possible, but theoretically, but I'll not go for this option, because theoretically that severe hypoproteinemia is required for the generalized edema formation, and then only the total blood volume will be decreased, and in that cases renal plasma flow will obviously decrease if the total blood volume decreases. But that is far away, बहुत ही मतलब okay. So that happens in ascites, I know, okay, happens in ascites because of that is other reason is also there, okay. Ascites, the other reason is also there, not only the decrease in plasma protein, okay. So decreased plasma protein, if it is severe, that can produces, but I don't think that you should mark here E, okay. It is better increased plasma protein can decrease the renal plasma flow, that is more option rather than decreased plasma protein, right? Okay. Now one thing I am asking here, that what is the relationship of the viscosity with the diameter? What is the relationship of the viscosity with the diameter of the blood vessel? If the diameter is less, what will happen to the viscosity? What do you think? What do you think? If the diameter of the vessel decreases, what will happen to the viscosity? Right? Right? Okay. So see here, please try to remember this effect. This is important for incoming GMR entrance examination, which is known as Farias-Lindquistic effect. So please remember, if the diameter of the blood vessel decreases lesser than 50 micrometers, so look at here, radius of the tube radius, okay, if the radius is less than 50 micrometer, right, what will happen? The viscosity, look at here, so y-axis is the viscosity. So what is happening? The viscosity is decreasing with decreasing in radius of the blood vessel. Whenever the radius decreases, right, less than 50 micrometer, then viscosity also decreases. But note down here, if you take only plasma viscosity, then it is not changing. Look at the two graphs, very important. So if you take only the plasma viscosity is not changing with the diameter of the tube, but the viscosity of the blood is changing with the change in diameter of the vessel. And what is the relation? Okay, the diameter, decrease in diameter also decreases the viscosity. This is very peculiar. Generally we think that if the diameter of the vessel is less, then the viscosity will be more, but that is not happening here. It is just opposite. I have taken this from a book. So what they are saying, that if the diameter of the blood vessel is less or small diameter, inside the small diameter vessel, we know what type of blood flow occur. There is laminar type of blood flow. Laminar type of blood flow occur inside a small blood vessel. So laminar blood flow means we all know that velocity of the blood flow is maximum in the middle part or the center of the vessel, and velocity decreases towards the periphery. So it is velocity decreasing towards the periphery. So because of this huge velocity at the center of the blood vessel, what happens? All of the cellular component of the blood, that is the RBC, they aggregate at the center of the blood vessel, and the plasma separated out at the lateral portion of this blood vessel. And because of all of this blood, all of this RBC is at the center, what will happen? The net effective viscosity of this blood vessel will be lesser than larger blood vessel, because in larger blood vessel, what kind of blood flow will occurs? Mostly turbulence kind of blood flow occurs, and because of turbulence blood flow, RBC remains in a haphazard condition throughout the blood vessel. But here, if you take a cross section, the RBC only present at the center of the vessel. This phenomena is known as the axial streaming of RBC, and because of this axial streaming, the net viscosity decreases. This decrease in viscosity in small vessel is known as Farias-Lindquistic effect, right? So this is the thing, please try to remember. This is not given in Guyton and Genong, but this is given in Johnson textbook of physiology, so it can be a future MCQ, right? So please try to remember. Okay, now coming to the next MCQ. So this is easy MCQ. Okay, and this is very pet MCQ. So I hope all of you will give correct answer in this MCQ. This is very easier one. Right. So true regarding fetal blood. True regarding fetal blood. Okay, so take your time and try to answer. Right, A is correct. A, B, D you are answering, so I'll ask you, write A. Let's wait for other also. Yes, right, A and E, A, B, E. Okay, all are correct. So true regarding fetal blood. Fetal blood has a high affinity for oxygen. All of you know why fetal blood has high affinity for oxygen. Why? If I ask you why, could you answer? Okay, the reason is this. Fetal blood does not binds with DPG. So please remember, fetal blood has high affinity for oxygen because it does not binds to 3-DPG. It does not bind with the 2,3-DPG. So please remember, so this option C and option D both are false statement because they do not bind with the fetal hemoglobin. Why? I am coming. Now here P50 of the fetal blood is lower than adult blood. Absolutely true statement. And fetal blood delivered high oxygen at the level of tissue. This is a false statement. Okay, right. Okay, because fetal blood, there is left shift of oxygen hemoglobin dissociation curve. Whenever there is left shift, it cannot deliver huge amount of oxygen to the tissue. Okay, so here answer is A and E. So please try to understand that quick discussion, that we know that fetal hemoglobin means alpha and gamma chain, right? But in adult hemoglobin we know alpha chain is there and beta chain is there. Now all of you know, please remember this important thing, that 2,3-DPG, they binds with the both beta chain. Means one molecule of hemoglobin can binds with only one molecule of 2,3-DPG. One molecule of hemoglobin can binds with only one molecule of 2,3-DPG. Now if I ask you 2,3-DPG binds with which chain of globin, that is your beta chain, both the beta chains. So please remember, this 2,3-DPG contain negative charge on its surface. There are 4 negatively charged molecule on its surface, and this beta chain, both of the beta chain, they produce a pocket like opening, and in that pocket, so if I imagine that there is a pocket here, inside this pocket there are total 8 positive charged amino acid here. There will be total 8 positively charged amino acid will be present surrounding this. Because of this positive charge on the beta chain and because of this negative charge on 2,3-DPG, they will interact with one another and they will bind with the hemoglobin molecule. After binding with the hemoglobin molecule, what will happen? The oxygen which are attached with this alpha chain, they will be released easily. The oxygen released from this alpha chain will be easy. That's why it is said that 2,3-DPG binding means there will be right shifting of the curve. That's why we say there will be right shifting of the curve, and we all know that whenever there is right shifting, there will be more release of oxygen at the level of tissue. Now in case of fetal hemoglobin, the alpha chain is there but beta chain is not there. Rather than beta chain, there is gamma chain. Now whenever the gamma chain is there, gamma chain cannot bind with the 2,3-DPG. That's why please remember, the fetal hemoglobin means higher affinity for oxygen, and we can say this is the left shift of the oxygen hemoglobin dissociation curve. Now because of the left shift, what is happening? The oxygen affinity is very high. What is the advantage of that oxygen affinity? If the oxygen affinity is high, then it will be easily take the oxygen from the maternal blood. The fetal hemoglobin has to take the blood from the maternal blood, so oxygen from the maternal blood. That's why oxygen affinity is high. This is helpful because it had to suck the oxygen from maternal blood, right? But because of the left shift, although the partial pressure of the oxygen in the fetal blood is very less. You know what is the partial pressure of umbilical vein? Around 30 to 36 millimeter of mercury. This is the partial pressure of oxygen in the umbilical vein. So look at here. The partial pressure of oxygen in our blood is 98 millimeter of mercury, but in case of umbilical vein, this is only 30 to 36 millimeter of mercury. So that means severe hypoxic condition. But because the left shift of oxygen hemoglobin dissociation curve, what will happen? Although the partial pressure of oxygen is less, but the hemoglobin will be saturated to a high level. Look at the curve here. Look at the curve here. This is very important. I have kept all these three curves for your information. So this is the adult hemoglobin curve, and this is the fetal hemoglobin curve. Fetal hemoglobin curve. So if I drop a perpendicular from this 50% saturation, so I can easily understand that the P50 of fetal hemoglobin is less and P50 of adult hemoglobin is more. Now I will ask you, please remember the P50 of adult hemoglobin is generally 26 millimeter of mercury. That means 50% saturation require 26 millimeter of mercury pressure. But in case of fetal hemoglobin, the P50 value of fetal hemoglobin is only 19 millimeter of mercury. That means value is less because of the left shift. So only 19 millimeter of mercury pressure is required for 50% saturation. And what I told, what is the partial pressure at the level of umbilical vein? That is the 30 to 35. So if you drop a perpendicular from this 30 or 35, then you can find out that if you drop a perpendicular on this fetal blood, you can find out that the saturation is around 80%, although the partial pressure is only 30 to 30 millimeter of mercury. So please remember this important information, that partial pressure of the umbilical vein is only 30 to 36 millimeter of mercury, but with this partial pressure the saturation of the blood here is around 80%, which is given in genome. And because of this saturation, because of this higher saturation, although the partial pressure of oxygen is less, but still it can deliver adequate amount of oxygen at the level of tissue. Plus you have to also consider that fetal hemoglobin means total amount of hemoglobin is also high. Fetal hemoglobin means total hemoglobin is also high, na? So that's why two things you have to remember. Fetal blood means this is high affinity blood, this is high affinity for oxygen, and second thing, this is high capacity for oxygen. What do you mean by high capacity? High capacity means total amount of oxygen that is carried by fetal blood. It is carrying huge amount of oxygen than our adult blood. Why? Because the total amount of hemoglobin is more, plus saturation is also not very less, it is around 80%. Because of these two things, what happened? The high oxygen capacity is there in case of fetal hemoglobin, and affinity is very very high because it binds less amount of 2,3-DPG, right? So this is all about the MCQ here. Got it, everybody? Okay, I hope everybody got this thing. Just give me a whether you understood this or not. Understood, right? So I hope you have also noted the carbon monoxide poisoning curve here also. Okay, so this is the carbon monoxide poisoning. So look at here, this is also left shift, this is also left shift of the curve, and look at the position of this curve. Here the delivery, fetal blood deliver high oxygen at the level of tissue. I told you adequate, this is not high. It will deliver adequate, whatever is required, but it will not deliver high delivery of oxygen is only possible when there is right shifting of the curve. It will deliver adequate, not high. Because delivery means oxygen has to be released from the hemoglobin, which is only possible if there is right shifting of the curve. If the hemoglobin is high affinity, it will only possible to deliver the adequate, not the huge. So this high delivery is not the true here. That's why I am giving that it is not true option. Now look at here, that carbon monoxide curve is also the left shifting of the curve, and fetal blood hemoglobin is also left shifting of the curve. But look at the position of these two curves. Carbon monoxide poisoning, this is completely shifted towards the y-axis. Okay, and here fetal hemoglobin, this is parallel, the shape of the curve is not changing here. Fetal hemoglobin, okay, the shape of the curve is not changing. So please try to remember, if the question is given as an image based question, so you have to identify that the shape of the fetal hemoglobin curve is not changing, but the carbon monoxide poisoning, the shape of the curve is changing. And what about myoglobin? Myoglobin curve is known as the rectangular hyperabola type of curve. Okay. Oh, it's parallel. Why it's parallel? Because the property of the hemoglobin, 4 globin chain is there. Okay, you know that the 4 globin chain is also present in adult hemoglobin, it is also present in fetal hemoglobin. That's why the shape of the curve is not changing, it is sigmoid in shape. You know the reason of sigmoid shape. Okay, fetal hemoglobin is not hyperbola. Hyperbola curve means it will looks like this, it will looks like this. This is known as the hyperbola curve. Fetal hemoglobin curve is also sigmoid shaped curve like that of the adult hemoglobin, but it is only shifting parallelly on the left hand side, right? Okay, only it is shifting on the parallelly on the left hand side, right? So these are the information that I have to remember here. Now look at this time, PGI Chandigarh has given another MCQ related to this same topic, that is the oxygen hemoglobin dissociation curve. Okay, another MCQ here. So this is more easier question in front of you, try to answer. Hyperabola is myoglobin, yes, hyperabola is myoglobin, right. Now try to answer here. Already we have discussed everything, so it is very easy to answer. All, exactly. So all are correct answer, all are true, A, B, C and D. So I am not taking much of the time here because all are true statement. Fetal hemoglobin left shift of the curve we have discussed, 2,3-DPG shift the curve to the right, carbon monoxide shift the curve to the left, we have already seen, and increase carbon dioxide tension favor oxygen delivery, that is the cause of right shifting, that is the cause of right shifting of the curve. So that's why all of the statements are true here. Okay, A, C, D, B is also true. Carbon monoxide causes left shift, carbon monoxide shifted the curve to the left, so all are true here, all are true here. Now coming to the, okay, so this is just to show you that different position of the curve. Now here all of the curve has been superimposed on one another. So look at here, this is the normal curve, this is the fetal hemoglobin parallel to the adult hemoglobin curve, and myoglobin curve, the shape is little different, which is hyperabola, and carboxy hemoglobin, the curve is located here. So this is completely left shape towards the y-axis. Okay, that we have already discussed. Now coming to the next question. Now this is a little difficult question. Probably this question been discussed in anesthesia. Okay, but try to look at the question and try to understand what they are trying to ask. Okay, in reference to time constant for pressure equilibration in respiratory tract, fourth statement has been given. Okay, you have to mark, right? Okay, so anybody could answer this question. So you must have to understand that what is this time constant, because the question is based on this. Anybody could answer? Time constant, you know, neuron, you have heard about time constant in neuron, AB, right? ABC? No. So please remember, ABC is not the answer. Here the answer is B, C and D. All are correct. A is not the correct one. Okay, A is not the correct one. So now look at what is this time constant. Okay, so just hold on to understand what is time constant. Now first of all, we know that whenever you take a inspiration, whatever is happening, there is a filling of lung is going on. Okay, now we know that, which is what is compliance, we know. Okay, compliance means it is a change of volume per unit change of pressure. We know this thing. Okay, that if you change the pressure, then there will be increase or decrease in volume of the lung, and lung filling or lung deflation will occur. Now I am saying, whenever the volume change is occurring inside the lung, if I want to calculate the time, that how much time is required to change the volume of the lung, then that time is part of this time constant concept. So what I'm saying, look at this curve first, what I'm drawing here. Okay, so x-axis I'll draw time, right, and y-axis I am going to draw the lung volume. Okay, so suppose I am starting from here. Okay, the volume which is present here is the residual volume. Okay, and above the residual volume, from the level of this residual volume, if you go up to the level of this total lung capacity, we know that this volume is nothing but your vital capacity. First you look at this, whatever I have drawn, you have understood this or not. This is simple, that apart from residual volume, if you remove the residual volume from the lung, what is the remaining volume present? That is the tidal volume, inspiratory reserve capacity, inspiratory reserve volume and expiratory reserve volume, and combination of all of them is nothing but vital capacity. So if I ask you, take a deep inspiration from this level of residual volume, so what the person will do, he will take deep inspiration and he will reach up to the level of the total lung capacity. Again deep expiration means again he will reach here. That is the normal thing, we know. Deep inspiration, total filling of the lung up to the level of the total lung capacity. Deep expiration, he is deflating the lung up to the level of the residual volume, because we know residual volume is not going out of the lung. This is the normal spirometric recording. But if I want to calculate the time on the x-axis during this filling of lung, what will happen? So now I am again plotting the curve. So person is taking deep inspiration, deep inspiration, deep inspiration, deep inspiration, and then the total filling of lung is complete. So suppose this is the ending point of the completion of this total lung capacity, right? Now I am asking that 63% filling, this number is important, this is a mathematical number. Okay, please remember time constant concept. This concept is coming from physics. You know the resistor and capacitor. If you want to charge the capacitor, okay, through resistor, then the definition of time constant is coming from there only. That 63% of charging of capacitor takes how much time? That is the concept of time constant. Getting my point? So it is the concept of capacitor and resistor. If I want to charge on capacitor, okay, then how much time I am taking to fill or to charge 63%? Why the 63%? If you ask, then I will say this is a mathematical equation, 1 minus 1 upon e, that is a natural logarithm. If you do this, then you are going to get 63%. But I am saying, please don't go into detail of this mathematical derivation. We don't require that because we are medical student. But here I am saying that during the filling of this lung, 63% filling taking how much time? If I calculate the time on this x-axis, this time will be known as the one time constant. Getting my point? So 63% I have to remember. Then so 63% filling of the lung has occurred, right? So how much percentage is still remaining? 37% is still remaining. Now if I take 63% of this 37, which is still remaining, then it will be around 23, I think. Okay, so if I add this 23 along with this 63, so that will be 86%. Means within two time constant, how much filling of the lung is going to occur? 86%. So whenever 86% filling has been occurred, how much is still remaining? Remaining is around 14%. So 14% is remaining. Now if I take again 63% of this 14%, then whatever I am getting here, if I add with this 86%, that is the volume of filling of lung in 3 time constant, that is around 95% of lung filling. Then with 4 time constant, there will be 98% of filling, and with 5 time constant there will be 99 to 100% of lung filling. So getting my point? So it is the 63% of filling is equal to 1 time constant, right? So in physics they define like this, that charging of capacitor through resistor 63% of charging of capacitor takes how much time? That is one time constant tau. Okay. Similarly, in respiratory system, the concept is filling of lung and also defilling of lung, that is the deflation, inspiration and expiration. During inspiration, this is the concept, and again during expiration, again the thing will happen like this. So again, that lung volume is changing. I am calculating that 63% dropping of lung volume, that means whenever I am reaching to 33% of total volume, that is one time constant. Okay, now look at the curve which I have taken from book. Okay, so the thing that I have discussed here, I am giving you the same thing here. So one time constant means it is the time which is required to fill 63% of the lung, right? Two time constant means it is the 85% to 86% of the lung is getting filled. So this is what volume? This is 100% volume. 100% volume is what volume? This is nothing but vital capacity, because we know residual volume is not going to get out of the lung. So vital capacity, if it is 100%, then within this 100%, 63% filling require how much time? That is one time constant. Then 85% how much time? That is a two time constant. And I told you how to get this 63% and 85%. Only you have to remember this 63% value. Then 85% is two time constant, three time constant is 95%, four time constant is 98%, and 100% or 99% is the five time constant is required. Similarly, when the lung is deflated, okay, expiration is going on, I am calculating the loss of 63% volume. That means what is the volume present inside the lung? 37%. Okay, so that's why it is said that during deflation, 37% lung volume is reaching at what time point? That is one time constant, two time constant, three time constant, four, and approximate again five time constant is required for complete deflation of the lung. So 5 time constant is required for inflation of the lung, 5 time constant is required for deflation of the lung, right? Okay, now what I will do with the concept of this time constant? What I will do? You have to remember that time constant is the product of this last way, airway resistance and compliance of the lung. So if I write down time constant is equal to airway resistance and compliance of the lung. So that means if I say, suppose the resistance of the airway is high. Suppose one person is suffering from obstructive disease. So what will happen to this R? The R is very, very high. If the R is very, very high, so what will happen to the tau or time constant? Time constant will also be very, very high. What is the meaning of that? Time constant is high. That means the lung filling will be very, very slow. That means you require huge time to complete filling of the lung. That's why remember, if the person is suffering from obstructive disease like emphysema, the curve will look like this. The slow filling of lung is going on like this. That means you require more time constant for complete filling of the lung. Okay, time constant is more high. Okay, so that's why remember, if the time constant is high, you require more time for filling of the lung. Right? So what will happen if the time constant is high? If the time of filling is high, what will happen to the respiratory rate? If you want to set the ventilator, what will happen? What have to be do with the respiratory rate? Respiratory rate has to be decreased, because it will take long time for filling of the lung, and similarly it will take long time for complete deflation of the lung. That's why we all know that emphysema patient has to take slow and deep breathing. So rate should be lower, because the time constant is high, because the resistance is high, right? So that's why look at the MCQ again. Okay, so here the MCQ first option, expiration takes longer time for pressure equilibrium as compared to inhalation. False stem. It takes 3 time constant to reach 95% of the pressure equilibrium. That is true statement. It takes 5 time constant, which is 99%. That is also a true statement. And time constant is calculated by the airway resistance and compliance of the lung. So that is also a compliance is also increased, but resistance increases much more. Very good question, that compliance is also high. Okay, so again the time constant will be high. Okay, concept of time constant will be high. Compliance is also high. Static compliance is high, but dynamic compliance is low. Okay, so please remember, compliance is also high in emphysema patient because of rupture of the lung, but because of rupture of the lung, the total lung capacity also increases. That's why it takes huge time for complete filling of the lung, and it takes huge time for complete deflation of the lung. That's why the rate of breathing must has to be lower down, right? So this is the concept of time constant, and all of the concept that we have discussed here I have written over here. Okay, so look at this, whatever written in the book. So when respiratory system is subject to change in pressure, okay, it needed some time to change in volume. Okay, that means increase or decrease in lung volume takes some time, obviously, and the time necessary to inflate the lung to 63% of its volume is called the time constant. Time constant is equal to RAW, that is the airway resistance, multiplied by C, that is the compliance of the lung. Time constant determine how rapidly lung will fill. If the time constant is high, then it will take prolonged time, right? And with each time constant, the volume change occur only 63% towards its equilibrium value. One time constant is equal to 63%. Okay, two time constant is 86% or 85%, three time constant is equal to 95, and four time constant is 98, and five time constant is required to complete filling of the lung, that is 99 to 100% filling. Okay, so this is all about today's class. This 6 question were asked in recent PGI Chandigarh question. So this is all for today. Now this is just for promotion purpose that I am taking this course, concise batch course for NEET PG examination, where 42 hours I have taken for physiology, and all of the question that we have discussed except for this time constant, almost all the concept we have discussed there. Okay, and if you want to join my course, that is the paid course in Unacademy platform, then please use my code, that is DRSOUMEN10, right? And please note down that my upcoming class, that is the neurophysiology part 2 MCQ based discussion, will be done. This is on 18 June at 7 p.m. Okay, and there is another class which is special for Zimmer, and this will be beneficial for the NEET exam also. This is based on exercise physiology concept, right? Exercise physiology concept, right? So this exercise physiology concept will be discussed on 20th of June, that is 1 p.m. Both of this class will be on Unacademy platform, that is Unacademy Learner app. You have to download the app and follow me there. You will get the notification of the class. Okay, so this is all about. Thank you very much. So please take amphibian graphs. So amphibian graphs are typically of MBBS. I'll try to take in future classes if it is possible. Thank you so much. Thank you so much for listening. Now I'm finishing the class. Okay, good night, take care. এখনো স্ট্রিমিং হচ্ছে নাকি?